All right. Hello, and welcome to another Move with a Doc. I'm Dr. Roopa Shah, board certified family physician and health and wellness coach. As always, with these, feel free to move or stretch or take a walk, get some sunlight, fresh air as we talk about women's health issues today. We're going to cover kind of three main areas. And then we will see if anyone has any questions at the end. But first of all, let's start by talking about just kind of the most basic of preventative care screenings for women, which is cervical cancer screening. So, in the past, if you're as old as me, you might remember you going to your physician and getting a pap smear every single year. This would involve kind of that vaginal exam with your physical every year, and that was routine. You just expected it. But that is no longer the case. Our testing has really advanced since then from the old fashioned, again, if you're as old as me or older, you remember the little tiny slides that they used to put the pap smears on. That's what we used to use. Even when I trained, that's what we used. We've really changed from this slide based technology to what we call liquid based technology or testing. So, what you'll see if you pay attention when you go to your exam, it's going to be in a little kind of a vial, and it's going to be filled with liquid. And it basically that's what the cells from the pap smear will go into. So, basically, because of this liquid based testing, we no longer need to have every year testing because it's just much better type of testing. Now, the goal of screening for cervical cancer is to find those precancerous cervical cell changes before it becomes cervical cancer so that we can get earlier treatment on board and prevent cervical cancer from happening. So there's a couple of main ways to screen for cervical cancer. Now, there is, from this liquid-based testing, we can do just what we call HPV testing, human papillomavirus testing. And this checks for infection with high risk HPV. Now, there's different types of HPV. Remember, HPV, human papillomavirus, HPV is the same virus that causes warts on your hands and your feet, plantar's warts. Those are low risk subtypes of HPV. What we're talking about in terms of cervical cancer is high risk HPV subtypes. And that's what we are screening for with your pap smear. Okay. So your doctor orders a specific test, based on when they take the sample, and they can order it just as an HPV test, or they can order it as a pap test. Okay. So if we order the lab order as a pap smear, we'll call it a pap test, a pap smear. It can also be called to, just to confuse you even further, cervical cytology. It's all the same meaning. We collect cervical cells, put them in that liquid-based sample, and then we can check for changes that might be related to HPV. Again, those changes, if left, and if they're precancerous, can turn into cervical cancer, although it's a very slow process. And then, so the first way I said was you can do just an HPV test. The second way is you can just do the pap test or cervical cytology. And the third is you can do the HPV with the cervical cytology, and that's what we call co-testing. So just to kind of break it down for you, but the co-test basically, as you would imagine, uses both the HPV and the PAP together to kind of screen you for your risk for cervical cancer and high-risk HPV. So, when do you need to get screened? That's probably the most important thing. Cervical screening recommendations have been developed by different organizations, just like there are for colon cancer and breast cancer. There's different organizations that come out with their recommendations. So there's the United States Preventative Task Force, which we've talked about before, the USPSTF, and then the American Cancer Society. ACOG has their own, American College of Gynecology. So how often you should be screening kind of varies just a little bit, but it basically is mainly standardized, and it'll depend on your age and your history of abnormal pap smears in the past. Now you're thinking, what if I had the HPV vaccine? That doesn't prevent infection. So back up. So the HPV vaccine is aimed at preventing high risk HPV subtypes. But even having the vaccine does not mean that you will never get high risk HPV and potentially precancerous cervical cells. It just can't protect you from all the different subtypes that are out there. But it is obviously better to be vaccinated because it offers a lot of protection. So the age breakdown is as such. Now, first of all, the best news is you don't have to get screened until you're age 21. Now, in the past, 16-year-olds, 17, 18-year-olds, we used to screen them. Now it's age 21, regardless of sexual activity. So anyone ages 21 to 29, that's when the USPSTF recommends getting your first pap smear at age 21. And then you're just getting that pap smear. You don't need the HPV testing. You can just get that pap smear every 3 years. And again, even if you're sexually active, you still don't need to get it before 21 unless you really wanted to. Of course, you could. And that's obviously not a substitute for any STD testing that someone might want to get. Now, women ages 30 to 65 years old, this is the group that needs the screening. And the recommendation is there's a couple of different recommendations. The one that's kind of most closely followed is the HPV with the PAP co-testing every 5 years. So basically, you're getting a pap smear result and you're getting an HPV result, and your doctor can show you those two after they've been done and kind of go over those with you. But that should be done every 5 years. And then if either of those is abnormal, there's a whole algorithm that will be followed. But generally, then you'll need, if the HPV is positive or the pap smear is abnormal, you would definitely need to be followed likely every year for a number of years until things kind of revert back to normal, hopefully. If you're older than 65, the good news is you may no longer need pap smears. Most women who have had normal results their whole life and have had normal HPV results, normal pap smear results, really probably don't need to be screened beyond 65. There's a few caveats to that. If you're immunocompromised, if you have HIV positive status, there's certain things where we may want to keep screening. So that's not across the board. But for generally for most women, you don't need to be screened after age 65. Okay, so let's switch gears and let's talk a minute about something that's a little uncomfortable for women to talk about. But I just had a gal yesterday actually coming in speaking about this, and that is female urinary incontinence. So again, this is sort of a difficult issue for women to talk about. It can be embarrassing because you're leaking urine or you're having accidents, or you're having to run to the bathroom. But it's really important that you speak to your physician about it because there are more treatment options than used to be available about this. It used to be you're aging, deal with it. It's just a normal part of aging. Now we're really encouraging women to talk to your physician about it because it doesn't have to be a normal part of aging. And there are things that we can do to help prevent it or to help fix it, and even medication options as well. So just to kind of break down, so if you're having these symptoms, there's a couple of different categories of types of incontinence you might fall into. I think the biggest one we're all aware of is stress incontinence. And this is that leaking of urine when your bladder's under stress or when it's placed under some pressure. When you sneeze, when you cough, you exercise, you lift something heavy, maybe you jump rope, it puts pressure on the bladder, and then that'll trigger a little bit of leakage or sometimes just a lot of bit of leakage. But if it's stress incontinence, usually you're only going to lose a little bit into your underwear. So that's stress incontinence. Urge incontinence is sort of different. And this is what maybe you've seen the commercials on TV for some of the different medication options, but this is that irritable bladder is sometimes what we'll call this as well. You have that intense urge to urinate, even if your bladder is not full. And sometimes if you can't get to a bathroom in time, this is when you'll leak some urine involuntarily as well. So urge incontinence, again, is associated with that feeling of frequency to urinate, that urgency to go right away. You're that person that's always looking for the bathroom when you go to the grocery store or to the airport. You're always, making sure you know where the first bathroom is because you know you're always going to have that urge to go. This is the type that's also made worse by things like caffeine, spicy foods, alcohol, things like that. Another subtype is overflow incontinence, a little bit less common, but this is when your bladder really never fully empties. So you may experience frequent or constant leakage of this small amount of urine. And this can happen when there's a blockage that prevents the bladder from emptying well. And overflow incontinence is actually more common in men due to some prostate issues than it is in women. And then the last type is just kind of that catch-all, as you would imagine. It's called mixed incontinence. So you have symptoms both of stress incontinence and urge incontinence, and we call that mixed incontinence. And again, more common in women. So some of the options for treatment, behavioral techniques. This is kind of what we call bladder training. So when you get that urge to go, we sort of recommend delay that urge just for a little bit. Start by just trying to hold your urine for maybe about 10 minutes every time you feel that urge to urinate. And the goal is really to lengthen the time between trips to the toilet, because you can sort of try to retrain your bladder and having it wait a little bit longer. The goal maybe is to wait every 2.5 to 3.5 hours. Another technique is called double voiding. It's just a way to help you learn to empty your bladder a little bit more completely to avoid that overflow incontinence. So double voiding means you urinate, then you kind of just take a breath, calm yourself for a couple of minutes, and then you try again. And more than likely, some women will urinate a little bit extra as well. Another technique is scheduled voiding, we call it, or scheduled trips to the toilet, just urinating, like I said, every 2 to 4 hours rather than waiting for that need where you feel like, oh, now I really got to go. So, at 12 o'clock you go, maybe you go at 3 o'clock and then 6 o'clock, and it just trains your bladder that you can go that long in between voiding. And then lastly, just managing your fluids and your diet. I kind of mentioned this before, but you may need to cut back on alcohol, caffeine, spicy, acidic foods, because these are all bladder irritants. And even just by reducing your intake of liquids in the evening, losing weight, these can all help to ease some of the issues with incontinence. Now, another really popular technique for incontinence is pelvic floor strengthening. You may have heard of these. These are those exercises we use to kind of strengthen that pelvic floor, which is what supports our bladder and our urethra. And it can really help strengthen those muscles as well. So these are those Kegel exercises that we may have heard of. They are very effective for stress incontinence, more so than urge incontinence. Not to say it won't help with the urge incontinence, but very helpful if you have that issue when you're coughing, sneezing, laughing, that sort of thing. So to do these pelvic floor muscle exercises, the best thing is sort of to imagine that you're trying to stop your flow of urine. So I think the best time to do them, I know people say, oh, do them in the elevator when you're, in your car. You can do that, but I think it's just better when you're on the toilet and going to the bathroom. So you just tighten and kind of contract those muscles to stop your flow of urine. And then you've done it properly. Once you get really good at that, yes, you can do it in your car, in the elevator, because you'll know exactly which muscles you're activating. And basically, you just want to hold once you stop your urine, maybe for like 4 to 5 seconds, and then relax for a few seconds, maybe another 4 to 5 seconds, and then try and contract again. And just work on seeing if you can hold each contraction for maybe about 10 seconds at a time. And if you can do this 3 times a day, that could be a really good way to help try and strengthen those pelvic floor muscles. It can be hard to kind of still even know which muscles you're activating. So physical therapy, talk to your physician about this, because there are some specific physical therapists that work with women just on pelvic floor strengthening and using biofeedback also. So definitely speak to your doctor about getting a referral to physical therapy, because this can be a really good first step for women who suffer from stress incontinence. Now, we also have a few medications that can be used. The first class, we call them anticholinergics. These basically are really good for that urge incontinence I talked about, that like quote unquote irritable bladder. They don't help as much with stress incontinence, although again, some women have that mixed incontinence, so they could be helpful. But these are examples, things like medications called Ditropan, Detrol, Toviaz, Vesicare. They basically they're an anticholinergic, so they work on the cholinergic system, but they will cause a little bit of dry mouth, occasionally blurry vision. So they can have some side effects, but I find them very useful in my patients. In fact, some women don't even feel the need to have to take them every day. But let's say you're going on an airplane, a long car ride, and you don't want to have to be stopping frequently to use the bathroom. They can be useful in those situations. Another medication, slightly newer in the market, Myrbetriq. This is used again for urge incontinence. This medication relaxes the bladder muscle a little bit, so it can increase the amount of urine your bladder can hold at one time. So this can also help you empty your bladder a little bit more effectively. So that one's called Myrbetriq. There's also, for men, more specifically, there's a medication that we use called alpha blockers. Remember, we talked about that men can have this overflow type of incontinence. These medications relax that bladder neck muscle and kind of make it easier for the bladder to empty. Medications like Flomax, Cardura, things like that. And then for women, another option I don't want you to forget, because sometimes, your physician, we can get focused on just the medications for urge incontinence, but topical estrogen, okay, or intravaginal estrogen, applying that in the form of vaginal cream, a ring, or even a patch can help tone and help rejuvenate those tissues in the urethral and the vaginal areas. And we're going to talk a little bit more about this later when I talk a little bit about HRT. But don't forget that as women age, part of the issue is that we're losing kind of that estrogen effect, and topical estrogen can be an effective treatment. Now, there's a few other kind of interventional therapies that are being used as well. So I just want you to be aware of them as well. One is what we refer to as bulking material. Okay, these are injections, whereas synthetic material is injected into the tissue around the urethra. Okay, and this bulking agent kind of helps support that urethra and keeps it closed a little bit to help reduce that urinary leakage. It's really used mostly, as you would imagine, for the treatment of stress incontinence, where we get that pressure, so the urethra kind of is what we call hypermobile, so it moves, and that's when you leak. So by kind of supporting that urethra with this bulking agent around it, you get less mobility and movement, therefore less leakage. And there's different names for those medications and such too. So, but talk to your doctor about those. Botox, yes, it can be used for so many things, but also it can be used into the bladder to benefit people who have an overactive bladder and urge incontinence. So this really generally is prescribed if all other treatments really haven't been helpful, but just I'm throwing that out there as a treatment option that can be used. And another option is nerve stimulators. So there's two different types of these painless electrical pulses that stimulate the nerves around the bladder. These are the sacral nerves. And one of these is kind of implanted into the skin around in your buttocks and then connected to wires on the lower back. So this stimulation of those sacral nerves really can help control overactive bladder. So not for stress incontinence, but overactive or urge incontinence is what the electrical stimulators can be good for. And again, use as a later modality when other things haven't worked, medication or bulking agents, et cetera. And then you could move on to trying something like that. And if none of these have worked, the medication, behavioral therapies, some things we just talked about, then of course, surgical procedures are an option. And you would want to see somebody skilled in these procedures to discuss what might be the best option for your condition. But there are sling procedures. You might have heard of these called sling procedures, where we but they place synthetic material, mesh basically, and they create this pelvic sling underneath your urethra and the area of thickened muscle where the bladder connects to the urethra, which is the bladder neck. And this sling basically helps keep the urethra closed, especially when you cough or sneeze. So this is a good option for stress incontinence. There's also a bladder neck suspension procedure, and this is really designed to provide support to your urethra and your bladder neck. Again, the bladder neck is that area of thickened muscle where the bladder connects to the urethra. And then there's prolapse surgery. So some women have uterine prolapse and some mixed incontinence with stress and urge incontinence. And their surgery might need a combination of a sling procedure and a prolapse surgery. Um, if you just repair the prolapse, that may not always fix the urge incontinence. So again, you need to see someone who's skilled in urogynecology, meaning they do a little bit of urology and gynecology and are really familiar with these types of procedures to know if you would benefit from prolapse surgery, sling surgery, a bladder neck suspension. So there's a lot of different options, and you would need a thorough workup to determine what would be the best option for you. All right. So let's move on to kind of just the last part of the talk. And I just want to talk a little bit about menopause. Um, so again, menopause and perimenopause. Remember, in perimenopause, those levels of estrogen start to decline from our ovaries. And this causes our periods to become erratic. They can become more irregular, heavier, more clots. But it's also responsible for a lot of those symptoms that we experience during perimenopause. As you know, there has been a really renewed interest in hormone replacement therapy, or HRT, as we call it. And I want to just quickly review here at the end some reasons that you might want to consider HRT if you're experiencing some of these symptoms. But again, I'm not advocating for it, but just to maybe think about, could you or would you be a good candidate if you wanted to consider it? So, the number one reason really women would want to consider this is just unrelenting hot flashes. So, what we call vasomotor symptoms, these are those hot flashes. They're the biggest reason most women would wish to go on HRT. These decrease your sleep quality. They can cause irritability, difficulty concentrating, problems with memory, and just overall reduced quality of life because they're so pervasive. They're happening during the day, they're happening during the night. Um, and oftentimes there's nothing much else that you can do for these. And this is really where HRT can really shine and help these women. So when they looked at, again, the Women's Health Study, they looked at which form of HRT was most helpful for these women. And it really didn't matter whether we did the oral, meaning the pill form, or the patch form. It really was just helpful with estrogen replacement for women with hot flashes. Another symptom, insomnia. Now, there are women that will have commonly sleep disturbances during perimenopause and even sometimes after menopause. Now, some of these women, the insomnia is associated with hot flashes. So those hot flashes can be disturbing your sleep, but there are also women that just have insomnia, just frequent wakenings. Or early wakenings. And again, just decreases your quality of life. So we know poor sleep can lead to mood fluctuations. You may feel more irritable. Your memory might suffer a little. We also know that poor sleep can lead to metabolic consequences, metabolic syndrome, obesity, and increased our cardiovascular risk, and even worsen diabetes. So sleep is important. And it has been found that HRT, hormone replacement therapy, can be useful in women who have some insomnia issues. Again, using lowest dose estrogen possible and progesterone might help with chronic insomnia. And it was found again that even the transdermal form, which is the patch, benefited women in perimenopause with insomnia, even again, so even if they didn't have those hot flashes, but just the insomnia alone, it seemed like it was beneficial. So something to consider. Another symptom is genitourinary syndrome. Genitourinary syndrome. Again, that's just a fancy word, but this just refers to kind of what we talked about earlier. The lowering of the estrogen really affects the tissue around the labia, the vagina, the urethra, and your bladder. So it can, the predominant symptom really most women are going to have is vaginal dryness. And we call this atrophic vaginitis. That, again, just a fancy word, but everything is getting dry down there. So you can have genital dryness, you can have burning, irritation. In fact, I just had a gal yesterday who was telling me this whole history of these UTIs that she was having. And I realized that she wasn't really having urinary tract infections. She was just describing this burning due to low estrogen. So the treatment for that is not repeated antibiotics for each quote unquote UTI when she really didn't have an infection. It was to treat the underlying cause of that. So now, some women with atrophic vaginitis or that dryness will actually get recurrent UTIs. So, if you are having recurrent bladder infections or urinary tract infections, think about or talk to your doctor about could this be related to that I'm postmenopausal or perimenopausal, and could a treatment be hormone replacement therapy? Now, for these symptoms that I just described, the vaginal dryness, vaginal estrogen, so not the oral and not the patch, but the vaginal estrogen can be a really excellent option. This could be in the form of a cream, a tablet, or a ring, and they all contain estradiol. When you use this form in this way, you do not have to take an oral progesterone. And I didn't mention it earlier with the insomnia and the hot flashes, but if you take hormone replacement therapy, you cannot just take estrogen. You have to take estrogen with progesterone. So we're talking about combined estrogen and progesterone when we talk about HRT most of the time. But if you use it just vaginally, you do not have to take a progesterone with it. You can just do an estrogen cream, tablet, an estring, which is the estrogen ring, and it can really help those symptoms. So, one more thing it can help with the vaginal estrogen is just if you have painful intercourse, because it can increase the lubrication and the blood flow, and even sensation in the vaginal tissues. It will not really help. It's not going to really help with libido. There's even some question whether or not the patch, like the transdermal patch people wear, whether that will help with libido. But it's certainly something somebody could try. And if you were looking for something to help with the libido, the patch, the estradiol, the Vival patch is what would be preferred, not the oral hormone replacement, because the thought is that the oral hormone replacement therapy can reduce what we call your bioavailable testosterone. It'll bind that up, which could then worsen your libido symptoms. So the patch would be what you would want to consider if you were thinking just about libido issues. And then the last one, osteoporosis, we know you don't really think of that as a symptom of menopause because you're not feeling that, but that is something that, of course, happens as we age and we get older and we go into menopause. So menopause is associated with increased bone resorption and the risk of osteoporosis. In that kind of hallmark study, the Women's Health Initiative, they looked at women's ages 50 to 79, and HRT seemed to increase the lumbar spine and the hip bone density and reduce fracture risk. So that's pretty significant. What they found is the HRT does improve bone mineral density, but just as long as you continue the therapy. So, and again, you can't take it for longer than about 10 years is sort of the recommendation. And to be clear, hormone replacement therapy is not a treatment for osteoporosis. So if you've been diagnosed with osteoporosis, you cannot, that's not the treatment, not hormone replacement. This is for women who are at risk for osteopenia or at risk for osteoporosis, but don't actually have that diagnosis. There is some benefit to HRT, but once you've been diagnosed, you have to use the appropriate therapy for osteoporosis. So in women who are younger than age 60 and within 10 years of menopause, oral hormone replacement therapy is potentially a therapy to prevent bone loss. And if you have premature menopause, so younger, like around age 35 or younger, then hormone therapy like birth control pills may also be a good idea to prevent bone density and reduce that fracture risk. And then last symptom that some women experience, and actually I just had a young lady yesterday who complained of this, but joint pain. So it's interesting, but they did find that estrogen binds to estrogen receptors on joint tissues, protecting kind of that biomechanical structure and maintaining overall joint health. So it's not exactly clear how estrogen works, like on what we call osteoarthritis, but there does seem to be a link. And again, in this woman that I saw yesterday, she'd been having a lot of kind of perimenopausal symptoms, and one of her biggest symptoms was that everything ached all over and all her joints. So in the women's health study, again, that kind of hallmark study, they did find that women who were on HRT and treated did have less joint pain, less joint stiffness compared to the placebo group. So if you only had the joint pain, I don't know that I would recommend hormone replacement therapy. But if you said, I am having insomnia, a few hot flashes, and joint pain, I think HRT could be something you might want to consider. So, boy, we kind of got late, so I will end here. Thank you so much for joining in, and we'll see you next time.